Welcome, everyone. Good morning, good afternoon, good evening. And it's my pleasure to welcome you to a webinar series, Session 3, Practical Education on Bleeding Disorders, Knowledge for All. My name is Glenn Pierce. I'm the Vice President of Medical for the World Federation of Hemophilia. This is the third in a series that we've run this year to provide for knowledge acquisition, education on practical aspects of bleeding disorders and what you need to know. In this particular session, we're going to be doing two different topics of comorbidities in hemophilia and bleeding disorders. One is musculoskeletal concerns, and those have been long-standing, of course, within the community and a part of the natural history of bleeding disorders, going back to the earliest times in medicine. And the second is a somewhat newer comorbidity, cardiovascular disorders, and those have arisen and become a bit more prominent in more recent years as individuals with hemophilia and other bleeding disorders have survived longer. And with that survival, it's realized that despite having a clotting factor deficiency, individuals are not necessarily immune to cardiovascular disorders. And so we'll be hearing more about that. If I could have the next slide, please. For the first sessions of our talk, of our session today, it's my pleasure to welcome Gianluigi Pasta, who is the chair of the Wfh Musculoskeletal Committee from Italy, Paul McLaughlin, physician at the Clinical Specialist Physiotherapist in the UK, and Adolfo Linnaeus, who is longstanding, been a volunteer and former chair of the Musculoskeletal Committee, who is in Colombia. And then for our next session on cardiovascular disorders, we have Robert Klamroth from Germany, Robert Schutkens from the UK, and Jerry Nolan also from the UK. So it's our pleasure to welcome all of our speakers and hear what they have to say with regard to both of these comorbidities. At this point, I will turn it over to Gianluigi, who will talk about MSK, comorbidities, osteoporosis, pain management, associated medical conditions, and surgery. Gianluigi, the floor is yours.
Thank you, Glenn, for your kind introduction and for the kind invitation to be here with all our friends for this meeting. I asked to have the opportunity to control my slides, and today I have the duty to talk about medical conditions associated with surgery and osteoporosis and pain. And these are my disclosures. I don't seem to have a conflict of interest for this presentation. And talking about MSK comorbidities, I think that I will try to show how the times are changed in the world of hemophilia, and maybe one of the first change that we had is an orthopedic surgeon talking about associated medical conditions. And I will try to do my best. And why we'll talk about something changing? Because of course now persons with hemophilia are aging successfully with the life expectancy similar to general population. And to manage this aging, we need a multidisciplinary program, a multidisciplinary team, and I will try to share with you my point of view about how to manage these conditions. When I started to be involved in hemophilia almost 20 years ago, of course, I was focused on surgery, and total knee arthroplasty was the gold standard to treat chronic arthropathy in an hemophilic patient. But we were scared about the rate of complication in this population. And of course, we were concerned about the need of surgical treatment on patient HIV positive. We were concerned about the higher risk of infection in patients with HIV infection. But during our practice, we realized and we published data demonstrating that HIV infection is well treated, it was not related with a higher risk of infection, a higher risk of complication. And it was something really crucial in order to give the right message to people with hemophilia, to colleagues not really involved in hemophilia, and really concerned about the risk to perform a risky surgery in people with hemophilia HIV positive. But of course, we still have a concern about the surgery in HCV positive, because all the 100% of the population of this review published some years ago were HCV positive. And we know that, of course, the management of hepatitis C could be really important in order to achieve better outcome after total knee arthroplasty. So the incredible improvement achieved during these years on the management of hepatitis C in general population, in persons with hemophilia, was really a great contribution to improve the short and long-term results after total knee arthroplasty in patients with hemophilia. But of course, we have to remember that there is a part of our population that is still had the problem of hepatitis C infection that is not totally cured, and it's something that you have to take in consideration inside the multidisciplinary team when you take in consideration to perform surgery in people with hemophilia. But it's clear that during these 20 years, we registered impressive improvement, and today is less a problem. Co-infection is not really a big problem, or is not really related with the results of surgery. And if it's true that we had change in the field of co-infection, we have to, I think that it's important to talk about what changed during these 20 years on pain management. And you can see how the number of publications on this topic increased during these years, and is becoming more and more a hot topic in the field in hemophilia. And this is really important, because I think that in the past we assumed that pain is something related with hemophilia. Also, as a musculoskeletal expert, we supposed that it was something, it's a part of our job, but it's not really important to standardize and to share information about pain. And this is clearly visible if you consider the scores, the clinical scores available to assess hemophilic arthropathy. You can see how the pain assessment has been introduced during these years, and how it's becoming more and more important to talk about pain, know the characteristics of pain in people with hemophilia in order to achieve the good management and the best treatment even in patients with hemophilia with a chronic disease. And if you look at the literature, of course, it's clearly demonstrated that the multimodal management of pain is mandatory in general population and in people with hemophilia. But sometimes I have the feeling that is not clearly used the term of multimodal. Multimodal is not step management, it's multimodal, it's something that could come together. And sometimes I feel that surgery is always just at the end of this process. As an orthopedic surgeon, I would like to remember that sometimes orthopedic surgery is the best painkiller available in terms of short-term results and long-term results. Of course, surgery has to always been explained in terms of risk of complication. But when you talk about pain, never forget surgery, never forget orthopedic surgeon. We are part of the team. We know that we have to take in account non-surgical treatment before, but when you realize that you are at end-stage arthropathy, when you realize that the other way to treat pain could be not enough, take in consideration surgery. Don't be scared about surgery, because in the right way, in the right place, in the right team, it's impossible to achieve excellent results in functional in terms of pain reduction. And another take-home message that I would like to give today about the pain management in hemophilia, I don't want to have the risk to think that only what is painful is relevant for hemophilic patient and for hemophilic arthropathy. But remember that we are really severe condition, really risky condition in people with hemophilia that are not painful. I think about silent bleedings. I think about chronic synovitis that is not always painful. I think about chronic arthropathy, because we know that we have patients with severe chronic arthropathy, with severe functional impairment and severe impairment of quality of life that are not really painful. And it's something that you are to think about. And you have to think that maybe sometimes surgical indication or indication for treatment is needed, even in a condition of without pain. So think that pain is really important to assess, is really important to treat, is really important to know, but it's not the only thing to look about a joint. It's not only the only way to treat, to find the right way to treat joint impairment. And the last part of my presentation is dedicated on osteoporosis, and I will try to share with you that, of course, also about osteoporosis, interest has changed during years, and we have more and more published papers during years on osteoporosis. And you can see from this slide that we have we raised the roof some years ago, but we still remained an interesting topic. But of course, it's something that we know from a long time. If you think that the first item of Peterson's score and published 40 years ago was osteoporosis. But when we talk about osteoporosis and people with hemophilia, what is only the bone mass density, or is this something different? And when we think about bone mass density, is something just related with the physical activity, with the genetic, with the peak bone mass achieved at 20 years old, or is something different? And we can use a definition of the NIH on osteoporosis. Osteoporosis is not only bone mineral density, that is the most important factor, but is also a question of bone strength, is a question of bone quality, is a question of increased risk of fracture. And when we think about osteoporosis, is an opportunity to all the community of hemophilia to think about the bone, because sometimes I feel, or I felt in the past, maybe there is quite a sort of racism on the bone. As orthopedic surgeons are the carpenters of medicine, the bone is the wood of the human body. It's not like that. Bone is absolutely the dignity, the molecular process of the related with this really active bone turnover, and we have to know more about bone in its process. And we have to think that hemophilia is not only related with osteoporosis and bone turnover just as a question of activity, but is also related with factor VIII in the complex mechanism of bone formation and bone resorption. And I'm sure that is really something that we have to think about in the past and in the present, thinking about the change of hemophilia treatment and the availability of new molecules. And we have to take into account that a deficit of factor VIII could be something related with the bone turnover. But coming back to bone mineral density, I would like to stress the fact that we are interested in fracture, because maybe sometimes we have the risk to have a surrogate endpoints of treatment. When we talk about osteoporosis, it's not talking about just mineral density, but is we talk about the reduction of fracture or risk of fracture risk. Is we are talking about quality of bone, and we have demonstrated some years ago that also in terms of quality, assessing that with the CT scan, it's possible to demonstrate that there is a correlation between poor bone quality in patients with hemophilia and the degree of arthropathy. But always remember that when we talk about bone quality of bone osteoporosis in hemophilia, is something different to bone defect or the large subchondral cyst. It's something different, and taking account that is something. These pictures are not related with medical treatment, are just related with surgical treatment, and I'm sure that Adolfo after than me will talk about this better than me. So of course we need to investigate on fracture rates on people with hemophilia, because the fracture is something really related with quality of life. And we have some papers that have demonstrated that in people with hemophilia, we can have an increased risk of fracture, and this is related with the treatment of hemophilia, and the availability of prophylaxis is able to reduce the risk of fracture in this population. So always remember that when we talk about osteoporosis, not only about from an orthopedic surgeon point of view, but our focus is the risk factor, and this is really well demonstrated in people with hemophilia, but also demonstrated in the general population. And we have to use all our tools in order to assess risk of fracture, because we need to prevent fracture in people with hemophilia. And of course, the rehabilitation program, a good rehabilitation program, is mandatory in this population, and I'm sure that Paul will discuss after about that. So when we think about MSK comorbidities, it's really more and more important to have a multidisciplinary team available, and all the specialists are needed, and in order to achieve the best results. So when you think about MSK comorbidities, try to think out of the box. It's not only a musculoskeletal problem, it's not only on your own field, it's something really important to discuss and to manage inside the multidisciplinary team. Thank you very much for your attention. I hope to give some food for thoughts. And now it's time to give the word to my friend Paul McLaughlin from UK. Thank you very much.
Thank you very much, Gianluigi. A great presentation and a lead up to my talk on MSK comorbidities rehabilitation. Just want to extend my thanks to the World Federation of Hemophilia for inviting me to talk to you all today on this comorbidities webinar. My name is Paul McLaughlin. I'm a clinical specialist physio based at the Royal Free Hospital in the UK. And so, there we go. I have no speaker disclosures other than my funded research. So today's discussion points on my presentation, I will introduce first off a case study of one of our patients, and then we'll work through looking at defining what rehabilitation is as a thing and as a concept, and what are the things that actually make effective rehabilitation, and seeing rehabilitation as an intervention within a biopsychosocial frame, and then hopefully some take-home points for you all to have a think about in your own clinical practice and your own experience. So my case study is an 18-year-old gentleman with severe hemophilia A. He has a history of bilateral ankle and bleeding and right knee bleeding, and his current prophylaxis is 2,000 units alternate day. The history for him coming to the for assessment was that for about 3 weeks he was reporting his right knee being painful. He told us that it was locking and giving way for no reason, although he could not recall and did not report any trauma, any injury, or any recent bleeding event. And there had been no change when he had actually taken extra factoriate in the pain or the problem with his knee. He was telling us that when he went downstairs and when he was going downhill, that he was getting more pain. So when we did that assessment and when we looked at his knee, there was no real obvious swelling in his knee. He did have an antalgic gait. Antalgic gait is when you sort of limp or you have a protective walking pattern for that right knee, and there was a bit of valgus deformation on that right knee. He did have full range of movement, active and passive. And when you had a feel and a palpate around the knee, there was some tenderness at the anterolateral joint line. He did have a measurable decrease in his quadriceps strength. And when we did the HAHS, the score for that right knee was 4. So not that bad, really. The scores go. Overall, his HAL, so his hemophilia activities, this questionnaire, he scored 76.5. And for those of you that don't know about the HAL, 100 is no perceived functional deficits or problems, and 0 is a huge amount of perceived functional deficits. And within that HAL, the domains of leisure and sport, household activities, and complex lower limb activities were the ones that scored the lowest. The main factor for him and the thing that was troubling him the most was that he was not able to play golf, and golf was his main hobby, and it was his main form of fitness as well, and socializing. So thinking about what might be going on, it sounded very much like a possible meniscal pathology given the sort of locking and giving way, but this arguably is very unusual presentation due to his age and without any overt preceding injury. The quad strengths and the fear with using his knee because then of the locking and the giving way and the sort of intermittent nature of that meant that we felt it was probably necessary and a good idea to give him a knee support and to instigate some very basic quads exercises from that initial assessment. However, he continued to get more pain and he had more visits in the next few weeks with us in the centre. So our initial point at that stage was to just get a check x-ray to see if there was anything overtly obvious in the knee, and this is his x-ray there, and there isn't a huge amount to see. in that X-ray. So that wasn't overly helpful from a clinical reasoning perspective. However, when we got an MRI follow-up a few weeks later, it was quite clear there was a well-defined subcondylar lesion there on the tibial plafond with marked bony edema. And the bony edema is this bright white event on the MRI scan there. However, the overlying cartilage was intact, as was all the sort of ligamentous and menisci structures within his knee. The initial diagnosis at that stage from the radiologist was that it was an avascular necrosis. So at that point, our medical input consisted of pain relief using COX-2 inhibitors, so Celebrex and Celecoxib is the anti-inflammatory use of choice, and pain medications which involve codeine and or paracetamol as and when he needed it. And we also tweaked his prophylaxis so that he was then on a daily prophylaxis regime of 1,500 units. And we felt that this is very much to manage the risk of bleed in the event of the knee locking or giving way, and also to sort of remove or moderate the effect of hemophilia on that knee as much as possible. Our physio input at that stage from a rehabilitation perspective was that we give him a lockable knee brace. And you can see the lockable knee brace here, we use a Donjoy. And so with that lockable knee brace, we were able to limit the amount of range that knee had. And so we actually had the lock on functional knee movement. And so that meant that he had enough range in the brace for things like normal walking and stairs. But the brace itself provided an external proprioceptive input where he then subjectively felt that his knee was much more supported and he began to have a bit more confidence in his leg completely. We got him into hydrotherapy pool because he had a fairly marked quadriceps, hamstrings and glute strength, so the whole kinetic chain in that right leg was problematic. And so we started off with hydrotherapy and then we moved on to a more gym-based activity. And at this stage, we were still able to use the knee brace. And because of the design of that knee brace, we're able to rehabilitate actively with that knee brace on. So you can then open the lock and actually the brace remains on, but it actually gives you as much range of movement that you need. So we work through closed chain and open chain activity for the lower limb muscles. But actually specifically for him, we were progressing towards golf-specific activity. And he is a golfer who swings to the left. And so if you can see that picture in the bottom right, you can see that his right knee is one that needs to move and rotate on itself, but also finish off being on his tiptoe as he rotates his trunk. And so that needs to be a very free and flowing movement and not one that is interrupted by anxiety about movement or a fear of locking or giving way. This is all rehabilitation. So rehabilitation happening over a period of months, and rehabilitation and introducing this concept that rehabilitation is more than an exercise, is more than physio. It is a process. It involves often many people. It involves many things at various time points along the problem in hand. So I just want you to keep that in mind in this and begin to have a think about this idea or the concept of what we see as rehabilitation. 6 months later, we had a follow-up MRI because we have now found this problem in his tibia. He is on a review process with the MRIs just to check on the health of that bone. And so the diagnosis was actually reviewed and then given as a hemorrhagic subcondylar cyst associated with hemorrhagiopathy, which is much more typical of what you would see in a person with hemophilia. The bone abnormality that was found 6 months ago was actually larger, and we could see that there was more intense bone edema remaining throughout that entire knee. And you can kind of see on radiology that arguably it may not look like that happy a knee. And then it's really about what the person attached to the knee thinks of that. And he was actually pain-free at this point. He was back to do 18 holes of golf, so a full round of golf with no problems. His knee felt subjectively better. It felt subjectively safer. He had a minimal need, if at all, for the knee support. His HJHS had actually improved on that right knee, gone from 4 down to 1. And his HAL, so his overall perception of his function, had actually improved to 90. And so this is where we have to really begin to think about when we define success by rehab, which metric we use, because actually if you continue to focus on biomedical metrics, so looking at x-rays or radiology or scan results, that actually you may miss the success and the lived experience of what living with a knee such as that means. And it also shows that, you know, this knee isn't going to go away. That is a problem that we will monitor, but actually at this particular point in time, his knee was pain-free and he felt that he was able to do everything that he wanted to do. And that's because we really need to see that the person with hemophilia, the person with a problem knee, or the person with a bleed exists within a life. And within that life, they deal with their health problems, they deal and monitor their work life, they have family and friends that they live with, go out with. They have a home, they live with people, or they live within a society. They do activity that they want to do, and they may also not do activity that they want to do based on some other problems or issues within that life. They may attend school or university, and they may want to holiday, and they may go on holiday. And actually being able to have active choice in all of these things is determined a lot by health, but actually health is determined a lot by all of the other things as well. And this brings us on to having a think about what is rehabilitation. Rehabilitation as a concept and as an intervention is that it helps a person be as independent as possible in everyday activities. That's the most broadest and most well understood definition of hemophilia, of rehabilitation, sorry. Rehabilitation also enables participation in education, work, recreation, and meaningful life roles. And you begin to see that actually that's a very individualized approach, and that's a very individualized form of rehabilitation, because actually rehabilitation is person-centered, and it should be person-centered, and it should actually be about the things that matter to them, the goals that matter to them, and the preferences they have within the life they want to lead. It can be done in any setting. It can be hospital, it can be home, it can also be within a private clinic. And actually, as we've discovered, it can also be online through telemedicine. It can lessen the impact of burden of other health conditions. And I think thinking globally, rehabilitation done well is an investment. It has positive cost benefits to individuals and society at large. And actually rehabilitation is for anybody who needs it. And this is where we sort of are currently across the board and on a global scale, is actually people being able to access rehabilitation for the things that they need and the things that they want. And that isn't always the case, and certainly maybe even more difficult for some people with hemophilia. Because rehabilitation really takes the whole person view. So thinking about that case study, you can see that there is a pathological issue within his knee. There's a pathological issue from the hemophilic arthropathy, and there is the pathological issue in regards to the instigating factor of his knee, which was his hemophilia. However, there was the personal context for him, and although he had hemophilia, bleeding wasn't the problem. His painful knee was creating issues with strength and stability in the knee, but actually more issues for him where he wasn't able to do his golf, and that was where he got most of his social contact and his physical activity. So that actually then interfered with his social participation. The impairment for him, yes, was the knee and was the locking and giving way, but it changed over time. And although the pathology had got worse, the temporal context, so across the timeline and the time frame of him living with his knee, changed. He felt better with his knee. His knee was dynamically more stable, although the pathology on MRI looked a bit worse. And so we really have to consider this entire whole person view when we're looking at rehabilitation and what we want to rehabilitate as well. So then what makes effective rehabilitation? So this is really considering taking a holistic, comprehensive assessment and understand the person who is in front of you. Excuse me. And so with somebody with hemophilia, that is trying to understand and empathize with what their actual lifetime experiences are of hemophilia, what their understanding of their overall health is, but also what bothers them right now. Why are they here with you in clinic? What has brought them to see you that is different? Is it their hemophilia that is different, or something about it? Or actually, is it a comorbid aspect of their life with hemophilia. Actually, having an expert MDT using a consistent and comprehensive approach is also known to make effective rehabilitation. Within hemophilia, that is the actual hemophilia MDT. But more importantly, I think it's being able to see rehabilitation as a key component and a key part of comprehensive care that is delivered by the multidisciplinary team, and it's not just a stick-on thing at the end, because we have to see hemophilia as a lifelong condition, and the comorbid aspects of that condition will change, will fluctuate, will get better, will get worse over time. It's based on a biopsychosocial approach and a biopsychosocial model. And that really is to help moderate and support behavioral choices. And that is not a clinician telling someone what they think they need to do. That is actually working through together to find things that they want and that person with hemophilia wants to do and wants to be able to do better. And we do that by acknowledging prior experiences. What has worked well before? What has not gone so well before? Why did that not go so well before for you? And actually this thing about understanding beliefs. What are people's beliefs around activity, around exercise, around rehabilitation, around pain? And actually rehabilitation uses many different tailored interventions. It may involve medications, pain relief, anti-inflammatories, factor concentrate. It may involve exercise and being more active, and it may involve psychological support. And for each person, this will differ. And some people may need only exercise, some people may need a form of everything or a mixture of 2 or 3 things. But also importantly for people with hemophilia, it's been able to monitor changes associated with the intervention and to make sure that the goals set are helpful for them and to check for harm, because actually when we rehabilitate, we need to make sure that there is no bleeding as a result of our intervention. We want to know, is there pain? Now, pain in itself is not a negative consequence of rehabilitation, but it's been able to understand pain within that context that actually sometimes I call this idea that I sometimes call good pain, that there is a point sometimes with some people in rehabilitation that you have to work through that pain to get to a better place of being able to manage that pain better. And actually, how do we measure what is changing for the better with that person in rehabilitation, and making sure that we're continuously reevaluating and having a look at the goals and are we doing what we set out to do. So my take-home message for everyone is that rehabilitation is a complex endeavor, and actually it is more than just a joint. It is more than just muscles. We have to, as clinicians, adapt and individualize any rehabilitation approach at any time point with the people we are working with. For some people, it may be looking at the joint muscles. For other people, it may actually be an accessibility issue. There is no one to help them do the rehab. There is no clinician available to them. For others, they have a little or limited understanding about their own condition, but also what perhaps rehabilitation could offer them. And so we have to be mindful that it is more than just the physical being, and it is more than just the joint health and the muscle function. And I think we have to embrace the complexity, and we have to accept and recognize that rehabilitation with people with hemophilia and with long-term conditions such as this is complex. And I think if we accept the complexity, we can actually get to the nub and get to the things that matter to people within that rehabilitation process. So thank you very much for your time. I shall pass mantle on now to my friend and colleague, Adolfo Linas, who shall talk about surgery and musculoskeletal conditions. Thank you very much.
Thank you very much, Paul. And I've asked to be able to handle my slides from this side. It's a pleasure to be here. Greetings to all colleagues around the world. We've heard from Dr. Gianluigi Pasta the backdrop for all of the complexities that surround the care of persons with hemophilia. And then Paul has taken us all the way up to the macro in terms of the holistic approach for rehabilitation. My name is Adolfo Linas. I'm an orthopedic surgeon. I work in not-for-profit hospital in a university setting in Bogota, in Colombia, and it's a pleasure to be here. And I need now to be able to handle my slides, if that's okay.
Dr. Linus, you should have control of the slides.
Thank you, Julia. I don't, but if you would kindly move the slides forward for me, then we can move on with the presentation. These are my speaker disclosures. I have no conflict of interest in relationship to this talk. Next, please. Now, what I plan to do during the next 15 minutes is to go deep into a very practical aspect of a condition which is typically seen around the world, and just to make sure that we're all aligned in terms of the way we manage these conditions. The starting point for musculoskeletal lesions is synovitis, and as you can see on the left, and that's the normal appearance of the joint. In the center, we have acute synovitis, and on the right, chronic synovitis, a very destructive condition that leads to joint destruction. Next, please. Now, starting from a reference point in our guideline, recommendation number 10.2.4 states that for patients with hemophilia who have unresolved chronic synovitis, WFH recommends non-surgical synovectomy as a first-line treatment. And the recommendation is based on isotopic synovectomy if you have access to isotopes. Next. This is the typical appearance of a joint that is in a chronic state of synovitis. So you can see the increase in volume of the joint. There's very little external inflammation, which is typical for acute bleeds. And you can see the muscle atrophy, especially in the proximal aspect of the thigh. Now, how do we do it? We use an anesthetic cream to minimize the unpleasantries of an intra-articular injection. We cover it with a translucent bandage, and we wait about 45 minutes for this to take place. Next, we produce an injection with local anesthetic. Next. And we make sure that we are interarticular, watching for the backflow of the cytokine that we just injected, or synovial fluid if there is no intra-articular bleeding. Next. If there is a recent bleed, then what you're going to get in the backflow, of course, is blood. You would need a thicker needle for that. Next. And if you have extra blood intraarticularly, it should be extracted to minimize the effect of radiation going directly into the red blood cells. You want the radiation going into the synovium. There are several isotopes that you can use depending on what's available around the world. Next, and it's very well known that the logistics of radioisotopic injection are complex. In places where radioisotopes are not available, and sometimes this is the case for us in Colombia, we use oxytetracycline or rifampicin. Next, it is characteristically recognized by its amber color. We precede the injection by intraarticular injection of cylocaine or lidocaine to make sure that you have numbing of the synovium, because this is a painful procedure, especially in the first injection. We also combine the procedure with oral analgesics. Now, following synovectomy, and it may take 1, 2, or 3 injections in the case of isotopes, and sometimes more in the case of oxytetracycline. And after working with rehabilitation, there are some cases where you will have residual flexion contractures. So you will have no more bleeding, but you won't get the range of motion back. So in these cases, we start by a combination of cast and wedging, which is a technique used for other orthopedic pathologies around the world. And in more severe cases, we use what we call desubluxation extension hinges. This is a simple procedure that requires some crafting in terms of our orthopedic abilities, but once again, around the world, there's a lot of experience with this technique. Next. The desubluxation is critical because there's a lot of retraction of the posterior capsule that prevents the gliding of the tibia forward. So these are some rudimentary hinges that have been copied from other ones that are more sophisticated. And you can see on the top left of your screen, the left knee being extended and protected in an extension cast, and the right knee in progress. On the bottom right of your screen, you can see both knees in extension. Next, please. Now, despite doing this, there are some patients in which you still have a vestigial flexion contracture, and it has to do with the posterior subluxation of the tibia, which you can see here on this knee of this young boy with hemophilia A without inhibitors, who is lying on his chest, and with gravity in his favor, you can see there's about a 25 to 30 degree flexion contracture still. Next. For this situation, we use a posterior release, and there are several techniques typically imported from the field of cerebral palsy and other pediatric conditions. And you can go from either side or from the center. In this case, you can see we're going from the center. You can see the nerves being retracted by the Penrose drains. And the posterior capsule, which is exposed at the bottom of the incision. We also release the origin of the gastrocnemius in this situation. And on the bottom portion of your screen, you can see the post-op situation where extension has been achieved. Next. Now, despite doing this, some of these patients can go back into contracture. And this is the case of the same patient where we achieved the extension, and then we lost some of that, and it was insufficient for full extension, which is inappropriate. So in these cases, we resort to next percutaneous supracondylar osteotomies. We see on the right an X-ray, which has been taken under maximum extension of the knee, and you can calculate the angle that would be required for full extension. It is frequent to see these osteotomies that have been in a wedge shape. We prefer a semicircular osteotomy in order to preserve length. This works very well with a very small percutaneous incision and the right chisels, which are designed so they can be placed through a very small incision. And of course, we use fluoroscopy to have some guidance during the procedure. Next, you'll see now a sequence of the osteodome going down, completing the osteotomy in the posterior portion, and going all the way across. Next. Then achieving extension, and next, and then fixation with guide wire initially. Next, and then cannulated screws from either side. Next, please. And next, and next. So you can achieve a fairly simple percutaneous fixation with the knee in full extension. Next. And that's the end result of the patient with extension on both sides. And the magnitude of this supracondylar osteotomy is not enough to distort the placement of the knee replacement in the future should it be necessary. So there's a limit to how much you can extend before you get in trouble with future procedures, and we keep that down to about 30 degrees extension. Next. Now, for patients with hemophilia, our guideline has this recommendation, and it says, following the postoperative period, they recommend gradual rehabilitation by a physiotherapist, which is experienced in hemophilia management. And each of these procedures, including the synovectomy, requires the multidisciplinary approach that is customary to anything we do in this format. Next. So I would like to summarize the sequence that I just presented. And it starts with a patient that develops a target joint. And here the recommendation is early synovectomy. It should be done percutaneously, ideally with radioactive isotopes. If not, with sclerosing agents like oxytetracycline or other medications that are used for this purpose. If you get full control and you rehabilitate the patient to the limit of their expectations, this is fine. If not, we move on to cast and wedges, or sometimes we use extension desubluxation hinges. And if that is insufficient, then we perform a posterior release. And if that doesn't work, then we resort to osteotomies. And if these 4 interventions are not within the realm of your zone of comfort as an orthopedic surgeon, then of course the multidisciplinary approach in Department of Orthopedics that has pediatric surgeons and reconstructive surgeons and other specialists, like for example, nuclear medicine specialists, can really, as a team, perform these 4 interventions that will eventually lead to full knee extension. Next. So I thank you for the opportunity of presenting this very linear sequence of talk, in contrast to what Gianluigi and Paul have presented earlier. And now I turn the word to Dr. Pierce once again. Thank you very much.
Well, thank you to all for those really provocative talks that outline a number of different parameters of orthopedic care. We have a few questions. Gianluigi, thank you for answering a number of them over the course of the last 30 minutes. And with regard to some of the additional questions that have come in, Gianluigi, I wanted to ask you to maybe give a little more information on the relationship between factor VIII and osteoporosis. So there's a lot of speculation in the literature about that relationship, and some of it to me appears to be marketing wars between factor products and non-factor products that in some fashion may obscure some of the truth that is important for us to be able to separate out. So can you comment on really what you think the role of factor VIII is in bone health, and what the absence of factor VIII means to long-term natural history of structural bone maintenance?
Thank you, Glenn, for this question. And of course, I always try to think with my own brain. And I remember that Professor Manucci, maybe 15 years ago, gave me an article about the hematological origin of osteoporosis. So, of course, it's something really known from the past, that maybe some coagulation factors, not only factor VIII, is related with bone formation, with the osteoblasts and osteoclast apoptosis. So there is some recognized cellular mechanism that could be, I don't want to say regulated, but could be in where some coagulation factors are involved. So of course, we have to think about that osteoporosis in hemophilia is not only a question of loss of function, but it also could be something related with the bone formation. Of course, we don't have definitely an answer to this question, but it's something that we are to work on. And once again, as we said, for the synovitis, for the chronic, for the arthropathy, the basic sciences in the musculoskeletal complications of hemophilia is something that we have to follow and to try to improve in our field, because it's the only way to have the final answer to the question, is the basic sciences. But at the same time, remember that osteoporosis is not a question of only of basic sciences. It's not only a question of medication, but it's especially a question of clinical results. The clinical results of osteoporosis is fracture, is not a BMD assessment. So I think that is really an interesting field in order to be able to use our knowledge on basic sciences and clinical applications. And don't to forget to think about your own brain, and don't be under the, of course, a lot of information coming from the market, not only from the world, but also about osteoporosis.
All right. Well, thank you, Gianluigi. We just have a couple of minutes, so maybe some brief answers to other questions. Paul McLaughlin, thank you for that really fascinating case description of the hemorrhagic cyst. And can you comment a little bit more about how prevalent that is, how it gets started, why it doesn't resolve in a more rapid fashion on its own? What's the natural history of that hemorrhagic cyst?
Well, it's complicated, but essentially the theory is that at some point after the bleeding, the cartilage, the cartilage layer of the joint has somehow been breached, and so the negative pressure within a joint sucks some of the synovial fluid down into sort of some of these bone formations, essentially. So it's both hemorrhagic in the sense that it's probably biomechanical as well, that after a bleed, the force transmission through joints changes, and so you may well have areas of cartilage being weight beared upon in a more abnormal fashion for longer periods of time. But it may also have some component of an avascular necrosis, where pressure inside a joint from huge amount of effusion somehow interferes with blood supply. And then, of course, you have sort of weight-bearing activity and sort of normal bone turnover and healing. And obviously, healing as a general concept is impaired in those with impaired hemostasis. And I think, you know, they're difficult, certainly as a physio, they're difficult to deal with because they generate a lot of pain, both the bony lesions, but also what we've really certainly found is the bony edema. That sort of unremitting, deep, horrible bone pain is quite difficult to manage. So, yeah, there's very little out there. Unsurprisingly, with some of this stuff, as Gianluigi was saying, that, you know, we lack basic science on mechanism, but we actually lack basic to translational science on how best to manage these in some quite young people. This isn't an old person's problem.
All right. Well, thank you for the comprehensive introduction to that subject. And Adolfo, perhaps one last question for you. The procedure that you used to create extension of the knee in the patient that you were referring to that had the flexure contractures, with the final procedure, was that patient able to maintain flexion, or was he immobilized? Was his joint locked at that point?
Thank you, Dr. Pierce. No, he's able to maintain flexion. It's a fascinating concept because you have a range of motion, which is, for example, 70 degrees full from wherever you start to wherever you finish. And the whole trick is providing that range of motion in the most convenient location, so Paul and his team can really work to regain as much of activity and independence as possible. So if you, for example, have 50 degrees of full range and it's in full flexion, it's very non-functional. So it's preferable to have it transported into extension. So we're keen about keeping motion. We typically don't fuse joints, perhaps with the exception of the ankle and subtalar joint. In general, we avoid fusing joints. So the beauty here is that you gain those last 30 degrees, which don't seem like much, but from a functional standpoint, it's a lot. Yeah. And this brings an enormous amount of well-being to the patient if you can achieve that. And Paul would probably tell you, if you can give me some extra 5 degrees of extension, because we're going to lose some, so just go ahead and hyperextend it just a tad. So when the patient comes back, he's in full extension, and you can see a wonderful result. A very simple procedure, percutaneous, very low risk of bleeding, and rapid rehabilitation, very little hardware. And most importantly, Piers or Glenn, around the world, there's so much talent in terms of orthopedic surgery in other areas that if you can recruit those surgeons that are extraordinary, treating trauma and pediatric conditions of patients who are non-hemophiliacs, if you can bring them in, lure them into the good side of the force, then we can get a lot of function back in these patients.
All right, well, thank you for that. I think that was a very comprehensive lecture as well as explanation for what you call as a relatively simple percutaneous procedure. So it's something that could be adopted in more widespread use. We are going to move on now to a different kind of a comorbidity, cardiovascular. And it's my pleasure to welcome Drs. Klamroth, Schutkens, and Dolan to speak to different aspects of cardiovascular comorbidities in hemophilia and other bleeding disorders. So with that, Robert, the floor is yours.
Thank you, Glenn. So a very warm welcome from Germany. I'm the head of the Hemophilia Center in Berlin here, and we are treating a lot of adult patients with hemophilia. Next slide. Here are my disclosures. You see they are balanced between companies who are active in the field of coagulation and hemophilia. Next slide. And we heard already that, thank God, the hemophilia population is aging. So we have more and more older patients with hemophilia. What is the disadvantage of aging for all of us, despite of the disease? That with aging, we have more and more comorbidities which are associated with age. And so, because the hemophilia population was a very young population before, and now with the new treatment, next slide, the new treatment possibility and the improved life expectancy, we see more and more elderly patients. And of course, first of all, factor replacement therapy improved a lot over the last decades and is more and more available in the countries all over the world. It's very heterogeneous, of course. In some countries, we have more replacement therapy and in others less. We have advances in the treatment of HIV, and we now can cure or eradicate hepatitis C. That's the main reason that we have more and more older patients with hemophilia. And now the classical disorders of the older age that are cancer and cardiovascular disorders are increasing. And that is a new challenge for physicians involved in hemophilia treatment. And of course, they all need knowledge for an optimal management. And if we look at comorbidities in patients with hemophilia, we should ask or focus on two questions. First, is this comorbidity more often in hemophilia? Is it due to hemophilia, like all the musculoskeletal issues? Or do we have difficulty in treatment in patients with hemophilia? Because in cardiovascular disease, that is a major point and will be tackled by Roger Chutkins and Jerry Dolan if we need anticoagulation in patients who have already the bleeding risk. I would like to start in the next slide with renal disease. And there's conflicting data. And the new Wfh guideline focused on the data that there is a higher incidence of renal disease in patients with hemophilia compared to the general population. That is different in different countries and different reported. But if you look at risk factors for renal disease, that's of course, I told you, for all comorbidities, age is an important risk factor, but it's hypertension, it's diabetes, it's HIV infection and combined antiretroviral therapy, among others, and it's the use of non-steroidal anti-inflammatory drugs. And if you look at the hemophilia population, there are a lot of patients who take regular painkillers, and painkillers like ibuprofen, for instance, as a non-steroidal anti-inflammatory drug causes renal disease. There was a long ongoing discussion if patients who have recurrent hematuria, if this is a risk factor for renal disease. So the hematuria itself is no risk factor. But recurrent infection, recurrent renal infection, of course, is a risk factor for renal disease. Next slide. So what is the reason so far that in the hemophilia population, there are very few reports of patients with hemophilia who require renal replacement therapy. You know, if you are on end-stage renal disease, you can get hemodialysis and peritoneal dialysis. So in my cohort of patients, which is quite big, we had only 4 patients with end-stage renal disease out of more than 300 patients with hemophilias of all severities. And there were only 2 patients with severe hemophilia A who had end-stage renal disease. The problem with hemodialysis is that hemodialysis requires anticoagulation to avoid clotting of the blood in the filter. And from my experience, normally you have 2 approaches. You normalize coagulation with replacement, and then you add anticoagulation with heparin. Or you count on that patients are somehow naturally anticoagulated. And my personal experience with these 2 patients with hemophilia on hemodialysis was they required no additional anticoagulation for hemodialysis and no additional factor concentrate. Both were on an immediate dose prophylactic regimen. And so I advocate for an individual approach in these patients because I'm sure that with time and the older population, we will get more patients with hemophilia who require renal replacement therapy. Next slide. What we can do now. So I think what most of my colleagues and we do is there's a regular monitoring of renal function in older patients with hemophilia. What we should do, and I think that is done in comprehensive care centers too all over the world, that we should screen for risk factors for renal disease. And one major risk factor, which is quite common in the hemophilia population, is hypertension. Yeah? And we should go look for diabetes. And of course, we should advise our patients in the use of painkillers who have the possibility to destroy the kidneys and lead to renal disease. So if you now focus on hypertension, which I think is much more prevalent in the hemophilia population than renal disease, in the next slide, I would like to start with a patient case. From my point of view, a sad patient case. It's now nearly more than 15 years ago, but it changed a lot of our practice here in my hemophilia center. It was a patient with severe hemophilia A, 52 years old, HIV negative, hepatitis virus positive. He had a history of inhibitor development, and there was an ITI with partial success. So he had still a reduced half-life of factor 8. So with daily injections of 1,000 units clotting factor, he was doing quite well with no joint bleeds. If he interrupts for a longer period of time the factor replacement therapy, the inhibitor already popped up again. So it was, from my point of view, concerning his factor replacement very compliant. He had no joint bleeds and only minor traumatic bleeds with this regimen. Next slide. As a comorbidity, he had arterial hypertension and was on antihypertensive medication since the age of 40. And very sad, one day he died without any obvious cause. His brother found him dead in front of his bed, and the autopsy revealed intracerebral hemorrhage. So an intracranial hemorrhage. And what was the reason from my point of view with the prophylaxis of factor concentrate? He was very compliant, but he was not compliant at all with the use of his antihypertensive medication, because his brother found a lot of unused drugs in his apartment. And when I called his general practitioner, he said, yes, he had often high values. Yeah? Next slide. So intracerebral hemorrhage is still a leading cause of death in patients with hemophilia. If you look at the registry from the United States, there's still a higher risk for patients with severe hemophilia and a higher risk for patients with moderate or mild hemophilia to die of intracerebral hemorrhage. Prophylaxis seems to be able to reduce intracerebral hemorrhage in patients with severe hemophilia, but hypertension is a major risk factor for intracerebral hemorrhage for all patients, independent of hemophilia or not. And in patients who are on anticoagulation, on anticoagulated medication, arterial hypertension is a 7-fold risk factor for intracerebral hemorrhage. So control of hypertension, from my point of view, is crucial to avoid side effects like kidney disease and like intracerebral hemorrhage. Next slide. Why I think it's so important? Because hypertension is a cardiovascular risk factor which has repeatedly been reported among patients with hemophilia since a long time. Back in the 1980s, there was a first study, there was an increased incidence of hypertension. In a Dutch study, patients were twice as often treated with antihypertensive drugs in comparison to the general population. In Canada, there was 29% of patients were hypertensive in comparison to age-matched control subjects, and it was found hypertension was found more common in Italian patients with hemophilia versus age-matched peers. Next slide. Of course, it's always difficult to compare, so I like this a Dutch study where Roger, who is the next speaker, was participating, that you see that there is in all age groups a higher prevalence in hemophilia patients in comparison to age-matched controls. If we look in the next slide, we did a big study all over Europe, the H3 study. It was a cross-sectional study with more than 500 patients, different age. And there was quite a high proportion of patients with a known diagnosis of hypertension, with treated hypertension, and a lot of patients with high blood pressure. You see here the prevalence according to age groups. There's maybe slightly more in younger age. In severe hemophilia, the prevalence of arterial hypertension, but in the older age groups, more than 80% had arterial hypertension. We try to compare this in the next slide to a German cohort of patients with hypertension, and at least in the age groups from 50 to 59, there was a significant increase of for hypertension in patients with hemophilia in contrast to the general population. So why I'm showing this so extensively? Because hemophilia in a lot of studies seems to be prone to found more patients with arterial hypertension than in the general population. So screening, from my point of view, is crucial. Next slide, please. So hypertension is a risk factor for intracerebral bleeding and for atherosclerosis and for cardiovascular disease. Measuring the blood pressure is easy. You can do it in every visit in your hemophilia treatment center, and a treatment of hypertension is important in patients in hemophilia. And I'm happy now that we close with the recommendations of the new Wfh Wfh guidelines, which I think are good from my point of view, because first, for all patients with hemophilia, the Wfh recommends regular blood pressure measurements as part of their standard care. The reason is patients with hemophilia have often arterial hypertension. Next slide. And for patients with hemophilia, the Wfh recommends the same management of arterial hypertension as applied in the general population. So the antihypertensive drugs doesn't interfere with hemophilia. So they have no bleeding risk. They don't interfere with replacement therapy. So treatment of hypertension there's no difference to the general to the general population, and so it can be treated, from my point of view, quite easily for doctors who are specialized in internal medicine. Thank you very much, and I will now hand over to Roger for the second topic of cardiovascular comorbidities, and he will focus on atrial fibrillation and the very different topic of anticoagulation. Roger, welcome.
Thank you, Robert, and thank you for this very clear recommendation, which I highly echo. Really nice talk. I was asked to give you a presentation about atrial fibrillation and the use of anticoagulation, and this is my my institution. I am not, as the very first slide of this session, I'm not a physiotherapist from the UK, so I really don't have the skills to be a physiotherapist. I'm a hematologist, and I'm head of the Van Greveld Clinic, a large hemophilia center in Utrecht. Now, I'm supposed to have control. I do. These are my disclosures. None of them related to my talk today. Now, the question is, can we actually anticoagulate a patient with hemophilia? And almost 10 years ago, we had these real clinical issues, and we had some patients with a myocardial infarction or in need of oral anticoagulation. And then we set up a local guideline, and we said, well, if you have a factor 8 or 9 level of 1 to 5%, it might be okay. If it's more than 5%, you can easily use aspirin. And we've tried that several times, and it worked pretty well. But on the other hand, if you have a severe hemophilia patient without prophylaxis, the use of aspirin led to a large mucocutaneous bleeding tendency. So we stopped doing that. So we made a similar thresholds for the use of vitamin K antagonists by that time. There were no DOACs 10 years ago. And we said that it's a safe zone to use them when you have a trough level of around 30%. We don't use it underneath 20, and between 20 and 30, you have the individual choice. Well, I was very happy that a couple of years later, there was a How to Treat in Blood that actually used the exact same trough levels. Then again, based on single experiences of local experts, not based on real large trials. And I can tell you, there are no real large trials. Now, hang on, yes. From the advanced study group that studied cardiovascular disease in the elderly hemophilia population, we made a Delphi consensus guideline, and we asked a lot of experts, what do you think is a safe threshold to start anticoagulation in your hemophilia patient? And basically, you see the same numbers. Use of antiplatelet monotherapy, around 3% is safe with a range of 1 to 10. The use of vitamin K antagonist, the experts said, well, you need around 24%, so between 20 and 30%. And the same goes for DOACs, newer oral anticoagulants. Now, in the meanwhile, we were trying to look at what is the real potential for making clot when you have a hemophilia patient and when you have a normal patient, so a non-hemophilia patient without hemophilia, but using oral anticoagulation. So we did this trial in measuring thrombin generation, so ETP. And here on the green bar, you see normal controls, no hemophilia. Oh, what's happening here? Okay. In the green bar, you see normal controls, no hemophilia, and no use of oral anticoagulation. In the purple bar, you see a patient with an INR that is above 2, so between 2 and 4, which is in the therapeutic range. In the light blue, you see patients that are using vitamin K antagonists in the subtherapeutic range, so an INR between 1.5 and 1.9. And then in the red bar, you see a severe hemophilia patient without factor VIII, so that had a washout of 72 hours. So when you have a patient on-demand therapy, not using prophylaxis with severe hemophilia, he has exactly the same ETP generation as a patient on therapeutic vitamin K antagonists. And when you look at your mild patients between 1 and 19, you see that they're actually pretty good anticoagulated by themselves, pretty close to the 1.7 of the subtherapeutic, and some of them really are in the range of the therapeutics. And then when you look at the yellow bar, the real mild patients above 20%, you see that the majority does not have a complete diminishing of their ETP generation. Some of them do, some of them don't. Actually, we're not that sure, but you can see that a cutoff of 20%, at least when you're having a factor level underneath 20%, you are probably already pretty good by your own. Trying to forward, yes. This is a recent study from France, where they documented the use of oral anticoagulation in patients with hemophilia, and they compared that to control patients, and they compared bleeding rates. And what you see is that you have an increased bleeding rates in patients with hemophilia on oral anticoagulants or antiplatelet therapy, as long as you're not reaching the 20%, and you can see that that increase in bleeding rate is 0 when you have trough levels above 20%. So we were not that wrong 10 years ago. So probably a threshold of 20% is a rough ballpark to start anticoagulation. They also demonstrated in that trial that there are a lot of more risk factors for having a bleed, not only the severity of hemophilia or your prophylactic treatment on demand of prophylaxis, but also the type of antithrombotic treatment, so aspirin monotherapy or clopidogrel or dual antiplatelet or even oral anticoagulation. They all have a different influence on your bleeding rates. And also the Hess-Bled score, and I will show that score in a minute. This is also a striking figure from that paper that actually shows that patients with hemophilia have worse outcome in the next 2 years compared to the general population. And probably, but I'm not sure, because we are afraid to treat them properly with oral anticoagulation or with antiplatelet drugs. So keep in mind that also hemophilia patients in need for antithrombotic treatment, they really need it because they are doing worse in the end. Now, when you talk about atrial fibrillation, you talk about stroke prevention. And in the general population, the prevalence is approximately 1%, but of course it increases while aging. And you can see that the percentage of men above 70 years having AF goes to 5 to 6%, and goes up to even 12% in the very high aged. We did a similar trial in the European cross-sectional study, and we found an average AF prevalence of 0.84%, and indeed the same increase in atrial fibrillation prevalence increasing with age. So your patients aged 60 or older have a prevalence of about 3.5%. Now, in the general population, there are a lot of guidelines out there to treat them. And this is the ABC pathway, the atrial fibrillation better care pathway, and I will focus only on the anticoagulation part. And in the general population, when you have a patient with AF, they identify a patient at low risk, and they do that by using the Chex Passcode. I will show that in a minute. And when you have a very, very low chest vascular, you don't need anticoagulation, but as soon as you have 1 point or more, you start anticoagulation based upon your risk for bleeding as well. And here is your Chex Passcode. It's a very easy score to do. You can look it up on the internet and you can fill it in pretty easily. And you can see that, for instance, when you have hypertension or age, you can get a score of 1 or 2, and a Chex Passcode or 2. That means that you have an annual risk of ischemic stroke of 2%. When you have a Chex Passcode of 5, that means you have an annual risk of ischemic stroke of 6.7%. So the higher the Chex Passcode, the higher risk of ischemic stroke each year. This is the Hasblad score that uses, again, pretty easy to fill in these clinical characteristics for your patient. And you can see that the higher the score, the more chance of having a bleed per year. So this is also a percentage. So you see a Chex Passcode of 2 has a risk of ischemic stroke of 2%, but a Hasblad score of 2 has a risk of 2% of bleeding. So actually that equals out. And to take an average hemophilia patient, let's say a moderate hemophilia patient with a factor VIII level of 5% or 4%, age 70 years, he has a risk of hypertension of being 80%, so he probably has hypertension. His age is 70, so he has a Chex Passcode of 2, which means an annual risk of 2.2%. And his Hasblad score is, well, bleeding is hemophilia. He has an age of 70, so he has a Hasblad score of 2, Hasblad of 2 as well. Now, based on this, and this is a big disclosure, this is not as a flowchart to use immediately. This is a flowchart to think about and to negotiate this with your patient, because not every patient have the same bleeding risk, not every patient has the same ischemic stroke risk, but this is a way to incorporate these scores in your clinical practice. So when you have a hemophilia patient with AF and you have a baseline factor level of more than 20, so the real miles, then you look at your Chex Passcode. When it's low, and with that I mean less than 2%, I would not advise to give any anticoagulation, because the risk of having a major bleed with any form of anticoagulation is 1 to 2%, and that probably does not outweigh the risk for ischemic stroke. Then again, when your stroke risk increases, so a Chex Passcode of 2, 3, 4, or 5, then you look at your Hasblad score again. And when your stroke risk outweighs your bleeding risk, you might consider oral anticoagulation. And nowadays, I use low dose dabigatran, a DOAC, 2 times 110. However, if your bleeding risk outweighs your stroke risk, then go back at your Chex Passcode again and really look at your stroke risk. Do you really need to anticoagulate your patient with a high bleeding risk? And I would only do that when my stroke risk will be very, very high. And we don't know what very high is, but at least raise the bar to 4. So when your Chex Passcode is not 4 or higher, do not use anticoagulation, because the risk of your treatment is not that big. Then again, when you have a real high stroke risk, but you also have a real high Hasblad risk, then there are alternatives, and I will talk to you that in the middle. You can use catheter ablation or left atrial appendix disclosure, and by that you can avoid using oral anticoagulation altogether. Now, when you have a patient that has not a real mild hemophilia, so let's say he has a factor VIII level of less than 20, and I would like to stress once more that figure here, less than 20, that means he probably has oral anticoagulation by nature. Then you should again look at your Chex Passcode. You probably do not need oral anticoagulation anyway. And if you do, then you really should have a high Chex Passcode. And basically we try to avoid that by using catheter ablation. And catheter ablation, we did that in a couple of patients in our center. And you can see here our 6 patients that we did that over the last 5 years. And for the sake of time, I will show you the results. We did 8 PVIs, so pulmonary vein isolation in these patients. Oh, the slide is going back and forth. There we go. Okay, this is a bit funny. Now, I hope it sticks on this. You can see we did 8 catheter ablations. In the older days, we used vitamin K antagonists, and we used a bridge of LMWH, so heparin. Then we saw large groin bleeds. But as soon as we switched to low-dose dabigatran, we didn't see groin bleeds anymore. And all of those patients were off atrial fibrillation and off oral anticoagulation for the period thereafter. So it was really successful. This is a very recent case report that described a typical mild hemophilia patient, age 76. So you can see this patient had a very high Chex Passcode score of 7 due to heart failure, hypertension, aged, previous stroke, and vascular disease. And his Chex Passcode score of 7 means an annual stroke risk of approximately 10%, but his bled score was 5, and that was even higher, 12.5%. So this is a typical patient where your bleeding risk outweighs your stroke risk. And they did a left atrial appendix closure, and it was very successful. And they did a review of the literature. There were 9 patients so far that had this procedure, always high Chex Passcode score. They had a single or a couple of days factor replacement. They closed the left atrial with a device, a Watchman device. And after that, you can use mono platelet therapy for long-term, or you can stop altogether. And it was very successful. But you need a surgeon or a cardiologist who can do that. So to conclude, atrial fibrillation is an emerging issue. It will come to you. If you have not seen it yet, you will see this in the near future. Anticoagulation therapy in persons with hemophilia is feasible, but it really needs an individual approach. And I would strongly advise to talk to your patient and tell them the risks of bleeding, tell them the risks of strokes, and together decide what's best. So with that, I would like to finish my talk, and I would hand over to Gary Dolan from the UK. Thank you.
Thank you, Robert, and thank you very much for the invitation to speak to you today. I'm just going to see if I can move these myself. Looking for screen share. Can we have the next slide, please? So I'm going to talk about ischemic cardiovascular disease, and these are my disclosures. Next slide. So I think one of the questions over time, which I think we've largely addressed now, is cardiovascular disease a problem in individuals with hemophilia? And as Robert and Roger have already discussed, are the classical cardiovascular risk factors the same in persons with hemophilia? And then when it does present, how should it be managed? Next slide. Okay, so, there have been a number of studies in the past, and as Robert introduced in his talk, individuals with hemophilia have a life expectancy pretty normal now. And there has been an increased focus on the range of conditions that might affect an individual throughout life. And one of these is ischemic heart disease. And you can see from these older studies that in fairly large numbers of patients, that they suggested that individuals with hemophilia had a lower mortality rate from ischemic heart disease compared to the general population. And it had already been noted that carriers of hemophilia appear to have a reduction in the more severe manifestations of ischemic heart disease. Next slide, please. Now, this slide is from a report back in 1983, and why did I show it? And I think it's because this was from a large hemophilia centre in the UK, and they were very surprised that 2 of their patients had bad episodes of ischemic heart disease. The first patient was 57 and he lived out in one of the remote islands in Scotland, and he suffered a fatal myocardial infarction after he received intensive factor replacement for a hematemesis. And that circumstance is important. We'll discuss that shortly. And then they had another patient with severe hemophilia who had died of an unrelated condition, not from a bleeding problem. And they were surprised that he had very severe coronary artery atheroma at autopsy. And this was clearly from these, esteemed physicians. They were not expecting that to be a feature of individuals with hemophilia. Next slide. And in fact, there have been a whole number of reports, and even this review from a number of years ago had already demonstrated it was, quite a number of acute myocardial infarction and cerebrovascular accident in individuals from a fairly wide range. And one of the interesting features was that a large percentage of these patients, they had their thrombotic event, their ischemic event, following treatment with factor replacement therapy or bypass therapy. Next slide. And there have been epidemiological studies looking at the underlying cause of ischemic heart disease, and that is atherosclerosis. And in these studies, which looked like they studied the key blood vessels using an ultrasound technique to look at the thickening of the vessel wall. And they found that there was no real difference in individuals with hemophilia compared to non-hemophilic controls. Next slide. And then finally, in this autopsy study from an increased number of patients than the previous case reports, and this was from the US, looking at individuals with hemophilia and looking at the degree of atherosclerosis on an autopsy study, they found there was no significant difference between individuals with hemophilia and controls. Next slide. So I think this means, or my interpretation and that of others, is that this diagram shows this deposition of atheromatous plaque in the arteries of the coronary arteries or other arteries. So that process is not really affected, or it's not reduced in individuals with hemophilia. But when an individual has a heart attack, it's usually caused by narrowing of the blood vessel and then thrombosis in that very narrowed vessel. So it may be the factor deficiency in some way protects against the final thrombotic insult. And that's an important aspect of management. Next slide. And so this is a summary of the evidence that we have to date. Cardiovascular risk factors are there. They're similar and in some cases increased, as Robert presented. Atherosclerosis is pretty similar in individuals with hemophilia or not. And that individuals with hemophilia can have the final results of this atherosclerosis. They can suffer from myocardial infarction and other arterial thrombotic conditions. And so the hypothesis is that the reduced factor may not prevent atherosclerosis, but may reduce the risk of the final thrombosis at the site of a ruptured plaque. Next slide. So what does this mean for individuals with hemophilia? Because there are lots and lots of guidelines on how you should manage these acute ischemic events. And this is one from the European Society of Cardiology. Next slide. And essentially, there are key components. First is that you have to act quickly, and it's not sufficient for us to be unprepared when an individual with hemophilia presents at 11 o'clock on a Sunday night with an acute event. We need to have some clear understanding of how we would manage the patient. And it's important that the longer you leave the patient untreated, the worse the outcome. These patients are treated with antithrombotic medication, either antiplatelet or anticoagulant, and there are a number of mechanisms that can be used to help revascularize using a stent or using medical drugs or combination of both. Next slide. And this summary slide basically shows this balance. So in an individual who does not have hemophilia, then the risk of using antithrombotic therapy is generally regarded as low, and it's certainly in the patient's favor to treat with antithrombotic drugs to get the gain of managing a life-threatening event. But of course, with hemophilia, if you were to use antithrombotic medication, anticoagulants or antithrombotic drugs in an individual with very low levels of factor, then that might be catastrophic. And so there is this balance to achieve. First of all, you have to be convinced that you have to use them. And if you have to use them, how should you use them properly? And that will almost always include factor replacement therapy to adequate levels. Next slide. And this just is again another illustration of the general treatment of acute coronary event using a variety of drugs that we have long tried to avoid using in individuals with hemophilia. But because of this emerging population of older individuals who are the ones where these events tend to present in, we have these decisions on a regular basis now. Next slide. So, the guidelines to date have all been based on individuals without hemophilia. So there have not been many adaptations of these guidelines to focus specifically on individuals with hemophilia. And there have been approaches using this Delphi method. I think Roger pointed out in his presentation of the data on atrial fibrillation is that there's almost no such thing as large studies of these complications in individuals with hemophilia. It's a rare disease. The numbers of older individuals are still relatively small. And so the institutional experience of these events is low. So one way of getting around the absence of evidence is to try and control a consensual approach. And this is a Delphi method after the oracle at Delphi. And it basically is a way of trying to produce a rigorous system for guidance. And this was applied, one group that both Roger and I were a member of, to the European Society of Cardiology Guidelines on Management of Acute Myocardial Infarction. Next slide. And these were presented in hemophilia back in 2013, and they're currently being revised, and Robert is leading on this. Next slide. It's surprising, so there's lots of technical detail in it that I won't go into, but actually there are some important things that the cardiologists who were involved in the study and other non-specialists were pretty amazed at. And one is that really we have to absolutely try to improve the alert system for individuals with hemophilia so that when they present to a center, particularly one without a hemophilia treatment center, that the clinicians fully understand what they should do, which should be contact a hemophilia expert as soon as possible so that we can guide them through this very difficult situation. Next slide. We recommend that effectively patients should try to be managed as normal after they've had factor replacement therapy. And that's the number one feature of this whole recommendation. But still, these patients should be regarded as having a high bleeding risk. So for instance, there are things in the guidelines, such as the use of certain types of antiplatelet therapy that may not necessarily confer a great benefit from the antithrombotic point of view, but might increase the risk of bleeding. And so we wouldn't recommend that, for instance. But that we also recommend that this PCI, the putting in of a stent, is preferable in people with hemophilia, and the previous treatment, which is to give systemic thrombolysis, which is to administer drugs that powerful drugs that break up clots, is really not suitable for an individual with hemophilia unless there is no other option, because the risk of bleeding is too high. Next slide. And so it's important that the individual hemophilia treatment centers are aware of the guidance as up to date as possible, so that they have in place a system so that patients can be managed safely. As we say, these events tend to happen unpredictably. They happen out of hours. They can happen in outlying hospitals. And it would be a tragedy if our patients did not access the proper care or were given inappropriate treatment simply because there was a lack of consultation. So I think the conclusion of this short presentation to date is that patients do suffer from atherosclerosis and they are at risk of acute coronary syndrome, and that risk appears to be following intensive replacement therapy, and that we'd imagine is fairly logical based on the data to date. In the event of acute coronary syndrome or acute event, a hemophilia expert should be consulted immediately, and that may be the patient or the family phoning in advance just to make sure that the communication is of high standard. And in general, there should be no delay in replacing factor so that the treatment can be given as quickly as possible, the treatment for the acute coronary syndrome, so the patient is not left with poor outcome. And then fibrinolysis and PCI, they should be delayed until factor replacement has been administered, and that should not take long. The next question is about the protection of the stent. So if you put a foreign substance into a blood vessel, then it will stimulate thrombosis. And what we don't want is for an individual with hemophilia to have a stent and then it reoccludes because they haven't had adequate protection. But of course, these antiplatelet drugs can increase the risk of bleeding. And so we have to increase prophylaxis to help protect the patient from bleeding. And we often have to have careful discussion with the cardiologist, because if there is the opportunity to use a different kind of stent, which would reduce the length of time the patient is on antiplatelet therapy, then we should pursue that. And these modifications in stents are happening all the time. And actually, it's one of the issues that we ourselves have, for the hemophilia treaters, we are challenged that we should try to keep up to date with developments in this area as much as possible. Next slide. So this slide is illustrating an expression that we use in English all the time, which is closing the stable door after the horse has bolted. Next slide. So in simple terms, this means what can we do to stop this situation arising in the first place? And these are my observations in my long career in hemophilia. And that is that in general, physicians who are not involved in hemophilia tend to be a bit afraid of hemophilia, and they don't get involved. Family doctors sometimes don't get involved in the care, or it's delayed. People don't get operations because they're worried about bleeding without consulting us. And so a substantial number of patients with hemophilia, particularly our older patients, have learned to focus all of their care on the hemophilia center. And the overwhelming care that we deliver has been on preventing and treating bleeding, in managing musculoskeletal disease, and managing transfusion-transmitted infection. And that has totally dominated the patient's care. But it means, that these risk factors, which apart from age could be modifiable, like blood pressure, diabetes, and high lipids, who is actually dealing with those? Next slide. And in individuals with HIV infection, heart treatment has been literally a lifesaver, and it has allowed our patients to lead pretty normal lives. But there is evidence that the use of heart and, in fact, HIV infection itself, given that a number of patients had HIV before effective treatment was available, and there are all sorts of complex reasons why this may lead to increased atherothrombosis in individuals who are HIV positive. The effect on the endothelium from the HIV infection itself, the heart therapy itself, and there is some evidence that different forms of heart therapy may be preferable in individuals thought to be at risk of increased atheroma. And then these other risk factors, which patients maybe through stress or lifestyle may also be indulging in, which can increase the risk of thrombosis. So there are a whole range of modifiable risk factors which could prevent or at least substantially retard the development of atherosclerosis, so that individuals with hemophilia, and indeed the general population, can avoid significant illness. Next slide. And so, many patients don't access these primary care and other preventative medical programs. Next slide. So who manages weight management? Who manages exercise strategies? How actively do we get involved in stopping smoking? Do we actively involve ourselves in screening for blood pressure, diabetes, and lipid screening and management? And these are all important for a lot of individuals in the older ages. And in many cases, that's done by primary care physicians. But I think we have to be very clear that if it's not being done by primary care, that we take it on. There has to be a clear strategy for managing this, as I say, modifiable risk situation for our patients. Next slide. And, you know, we should reflect on what we are delivering for our patients. And I think primarily we should be aiming to offer a holistic healthcare program. And so, you know, comprehensive care, I think the original term was set up in the United Kingdom way back in the 1990s. And to be honest, it was largely focused on pediatrics and other complications such as liver disease and HIV, rightly so. But I think with this emerging population of older adults, I think we have to look and see, should it be adapted? I think in each country, healthcare systems are different. So I think we need to think what works best in our own environment. We need to work with primary care and secondary care systems to ensure that all our patients get good care. You know, we are doing a great job with increased prophylaxis, with increased treatments available for hemophilia, so that we're really good at managing the bleeding situation now. But it'd be a shame if the patients then developed other conditions because of a degree of neglect. And maybe you can even consider something like a patient passport, that the patient understands what needs to be done, and either they'd have that done in primary care or secondary care. Next slide. So I think in summary, you know, we've focused on all these complications, and I don't want people to feel depressed. In many ways, this focus on medical morbidity is a success story, because we're actually, for the last decade or so, we are generating longevity in our patients. They are looking forward to normal lifespan. And that's largely because their hemophilia therapy has been so good, both in the delivery of it through traditional comprehensive care, and also much more effective and safe therapies. And there's been a marked reduction in death from hemorrhage and complications of treatment. And this recombinant, in particular, recombinant technology has freed us from the risk of infection, and improved antiviral therapy has greatly reduced the risk from transfusion-transmitted infection. Next slide. But I think we should reflect on a regular basis, what are we aiming to deliver as hemophilia centers, and what should our patients expect from us? And I think we should be proactive in supporting our patients through all the challenges in later life. And I think there's a good case for us, you know, I think in hematology in general, speaking as a hematologist, we generally are quite holistic. And I think in hemophilia care, given this close lifelong relationship that we build with patients and their families, we are ideally placed to ensure that that care is delivered. And I think, you know, as an ongoing debate, we should have a review of comprehensive care and make sure it's fit for purpose for the future. So thank you for your attention.
Jerry, thank you very much for that comprehensive overview. And Roger, thank you too. And sorry about your affiliation. You are, in fact, head of the Von Crevaux Clinic. So we just have a few minutes left. I wanted to open this up to our orthopedists and musculoskeletal folks who are on the call as well. But first, let me just ask a question about non-steroidal anti-inflammatories. Robert had mentioned the risk to kidneys. We have gone back and forth with a variety of non-steroidals, recommending them, telling patients to avoid them. Can we get a little bit of comment from maybe a few of you on how we should be thinking about non-steroidal anti-inflammatories for the control of pain?
I mean, in general, is this for the orthopedic reviews? Yeah?
No, this is for all of you. You're all experts, and I just thought I would open this up to all of you.
Well, I'm sure Adolfo and Paul would agree that non-steroidal anti-inflammatory agents can have a major benefit in an individual with chronic arthropathic pain. But of course, we have these big epidemiological studies which suggest that they are associated with ischemic events, with cardiovascular events. And a lot of our family doctors in the UK are afraid of prescribing it for older individuals, whatever the underlying condition, for any length of time. I think for hemophilia, in hemophilia terms, we try to minimize the duration of the anti-inflammatories and try and use them in a sort of pulsed way. But ultimately, it depends on the balance of risks for the patients, looking at their other risk factors for cardiovascular events and their need for adequate pain relief, because they are often
Okay.
pain relief.
So any comments from other parts of the world? Adolfo, you're on mute.
Thank you. I was just going to say I agree with Dr. Dolan. We keep it to a minimum, essentially.
Okay, I've got another question that goes over cardiovascular and orthopedic concerns, and that is DVT prophylaxis post-major surgery. And can we get a few comments from you all on the consensus there? Should we not? How do we think about this? And maybe I'll start with Gianluigi. Oh, and give me short answers because we're almost out of time, please.
We use not to do thromboprophylaxis in hemophilic patients underwent major surgery. Indeed, just in case of a patient with some other risk for thromboprophylaxis, but routinely we don't use thromboprophylaxis for our patient.
Okay. Roger, any comments from your perspective?
Yes, actually, we do it in all our patients. We've been doing this for over 40 years in all our continuous infusion protocols. We perform around 100 surgeries each year in hemophilia. And my personal belief is when you give factor levels of 80-100%, there is no additional bleeding risk of low molecular weight and low dose, and you will only have benefit. And then we stop it after 1 week. But then again, it's a debate that is not closed yet, I think.
And would anyone like to offer a third opinion?
Yes, certainly. We use mechanical compression devices, intermittent compression devices, in a very systematic way, and we don't use pharmacologic prophylaxis.
All right. Well, I see that we are not going to be able to resolve this, but I think it is important to air it and make sure that our audience understands that we don't have full consensus on this issue, whether you have hemophilia or not, actually. Okay, so with that, let me close and thank you all for all of the efforts that you've put into these presentations. They're outstanding presentations. They'll go up on the website and will continue to be used for at least some foreseeable future. With that, thank you all. Thank you to the audience. Thank you to our interpreters for the audience, and to our WFH staff headed by Julia as the organizer of this. Very much appreciated. Everyone have a good rest of the day. Thank you.